Hepatic congestion is any condition that causes passive backup of blood into the liver. The most common cause is congestive heart failure, most notably right-sided heart failure. Remember, when the right side of the heart fails, the blood backs up and most often accumulates in the liver. Remember, left-sided heart failure can cause right-sided heart failure, which in most advanced cases can then result in passive liver congestion. This can cause what we refer to as the nutmeg liver. Notice in the picture here, you see the little freckling of the liver, which kind of looks like a nutmeg. In nutmeg liver, you get an enlarged, painful liver. Sometimes you can get a mild jaundice or a mild increase in the LFTs from the necrotic hepatocytes. It's the chronic congestion that leads to the fibrosis and eventual cirrhosis of the liver. Budd-Chiari syndrome is a completely different syndrome in which you get a thrombotic occlusion of the hepatic vein. There are multiple causes of Budd-Chiari syndrome, including idiopathic or unknown, polycythemia vera, pregnancy, oral contraceptives, PNH, or hepatocellular carcinoma. Budd-Chiari syndrome is characterized by central lobular congestion and necrosis. It can result in acute, painful hepatomegaly, portal hypertension, ascites, and eventual death from acute liver failure. The autopsy of a 60-year-old woman reveals a liver which is enlarged and tense with a blunted edge. Pre-mortem tests show hepatitis B surface antigen positive, anti-hepatitis B core total positive, anti-hepatitis C IgM negative. Which of the following underlying conditions did the woman most likely have to explain her liver findings? In this patient, you have findings consistent with hepatitis B. The patient has a positive surface antigen and a positive core antibody indicating in past exposure and chronic hepatitis. The most likely answer here is chronic hepatitis B. In the next section, we'll talk about hepatic neoplastic diseases. The liver can be divided up into benign tumors or malignant tumors. The benign tumors include hemangiomas, which are benign vascular tumors, usually incidentally found on routine radiologic studies such as CT scans. Or patients can have hepatic adenomas, again, another benign tumor, most often seen in young women taking oral contraceptives. Most hepatic tumors, however, are metastatic from the colon, breast, or lung, or even the kidney. Or patients can have primary hepatocellular carcinoma. Cirrhosis of any cause, particularly hepatitis B, C, alcoholism, or other diseases such as hemochromatosis, can cause hepatocellular carcinoma. Aflatoxin B1, found in aspergillus-infected grains and peanuts, can also be a toxin that results in hepatocellular carcinoma. Here you see a gross slide showing a multifocal or diffuse distribution of the hepatocellular carcinoma. Notice the greenish hue from the bile. It's most commonly seen in men, but usually peaks in the age of 60, and more common in Asia where hepatitis B is more prominent. You can usually see an increase in the alpha-fetoprotein in the patient's blood who have hepatocellular carcinoma. Hematogenous spread or metastasis via the portal and hepatic veins is common, and metastasis to the lung is the most common site. In the next section, we'll talk about biliary pathology, including cholelithiasis or gallstone formation, cholecystitis, inflammation of the gallbladder, cholangiocarcinoma or cancer of the biliary tree, or adenocarcinoma of the gallbladder. Cholelithiasis is another word for gallstones, or cholesterol stones where cholesterol stones are the most frequent, including 80%. Usually this is seen in females, obese patients, patients who are pregnant, or those using oral contraceptive therapy. The pathogenesis is that of supersaturation of the bile with cholesterol. Here you see a picture of a gallstone. Notice the yellowish stones in the gallbladder. You can see the cholesterol staining of the gallbladder mucosa as well. Bilirubin stones are usually composed of unconjugated bile and calcium salts. The etiology of this is usually hemolytic anemia, or cirrhosis, or bacterial or parasitic superinfection of the gallbladder. These here are different from the yellow stones which you saw previously. Remember, the yellow stones are from cholesterol. These black stones here either are infected stones or the result of hemolysis, or bilirubin. Cholelithiasis is usually asymptomatic and incidentally found on CT scans or radiographs as well. But it can also occasionally result in biliary colic, which is either right upper quadrant or mid-epigastric pain that radiates the scapula. The complications of cholelithiasis include cholecystitis, which is acute or chronic obstruction of the gallbladder, or choledocholithiasis, which is gallstones obstructing the biliary tract, which may lead to biliary pancreatitis, or cholangitis, which is infection of the biliary tract, usually behind an obstructed stone. In this section, we'll talk about cholecystitis. Acute cholecystitis is the acute inflammation of the gallbladder caused by cystic duct obstruction by gallstones. The usual presentation is right upper quadrant pain persisting greater than a few hours, nausea, vomiting, and possibly even fever and an increased white count. In chronic cholecystitis, you have long-standing inflammation of the gallbladder, usually caused by chronic cholelithiasis. Here in the picture, you see chronic inflammation and dystrophic calcification, which results in a porcelain gallbladder. You can also see A-shop sinuses present, which the arrow points to. Remember, this is a significant risk factor for cancer of the gallbladder. Adenocarcinoma of the extra or intrahepatic bile ducts, or in other words, cholangiocarcinoma, is the most common biliary cancer. The risk factors include primary sclerosing cholangitis, Chinese liver fluke, thorium contrast dye. The clinical pathology is usually that of obstructive jaundice or a painless, palpable gallbladder, known as Courvoisier's sign. Adenocarcinoma of the gallbladder is most often seen in elderly women. 95% of these patients usually have cholelithiasis and/or a porcelain gallbladder. It's often asymptomatic until very late in the course, thus the prognosis is usually poor. A patient presents with colicky right upper quadrant pain for 1 month with mild nausea. The patient's gallbladder is removed and demonstrates numerous green-black stones. Which of the following patients is most likely to develop the above condition? A 12-year-old African American male with sickle cell anemia, a 50-year-old male with ulcerative colitis, a 43-year-old female with jaundice, pruritus, and ulcerative colitis, a 50-year-old obese male, or a 25-year-old male with IV drug use. The answer here should be the 12-year-old African American male with sickle cell anemia. Remember that green-black stones are seen with hemolysis, in this case sickle cell anemia. A patient presents complaining of feeling acutely ill following heavy drinking. Physical exam reveals jaundice and upper abdominal pain. A CBC demonstrates leukocytosis. The arrow in the photomicrograph points to. These here are Mallory bodies. Notice again the bright pink staining.